It's excellent to see, especially in the field of COPD, having a tailored approach, I guess better expanded, correct? I mean, is that usually from what I've gathered from just coverage, the field of asthma in terms of tailored care is
Yes.
much more refined right now than it is.
Yes, true. Yes. There's good news and bad news. The good news is for a pulmonary specialist like me, it's wonderful to see how you have tailored approaches for asthma, for specific inflammatory types of inflammation, really changing outcomes in some of these trials. That's the good news. The bad news is that, Christ, COPD is also an airways disease. It's an inflammatory component in it. So we have to run very hard to catch up with new molecules and treatments that are out there. I think in all fairness, Ethos studies not a novel drug. It doesn't study a novel antibody. It is testing a principle of triple therapy, testing it with a very intriguing novel technology, sort of how to deliver these drugs to the lung. So this aerosphere technology, I think, is a very good platform for all sorts of medication. So it tests this as well. And it tests this in a large enough trial to deduce meaningful conclusions for clinical practice. I think that is why this is relevant. The other thing is that I probably didn't mention, we're getting closer to some sort of tailored therapy, maybe through one thing. What this trial did is it prospectively stratified individuals that had eosinophilic inflammation, more eosinophils versus those that didn't. And since it's large, you end up with large chunks of people with different levels of eosinophils. And what this trial again confirms is that the risk of a COPD patient with a classical history of the disease to be unstable, to exacerbate, the risk changes with the number of eosinophils in peripheral blood, saying that if you have a lot of these cells, your risk of being unstable is much, much higher. Having said this, it seems that in those individuals, the effect of a steroid is even bigger than in the overall population. So you know from the press release, and I think that I can disclose this, yes, this is a positive trial, it worked. The primary endpoint, and it was given, we made it fully. What's interesting is that even though for the whole population it's an efficacious treatment, these eosinophilic patients benefit more than others, and they particularly benefit from the steroid arm in the triple, which makes it very interesting. And so that is the first alley into more tailored approaches in that. There has been the debate to say, yes, in some of the COPD that is eosinophilic, maybe this is just a minor variant of an asthmatic disease that is covered by smoking in the past and having clinical signs of a COPD, but they are, if you want to call it, hidden asthmatics. Well, I think that's a fair argument. So you can only do what we did. You exclude people with an active diagnosis of this disease. Our individuals had a highly significant smoking history. Tens of years they smoked. They were bad. Their lung function showed sign of a COPD, all right. But notably, the number of individuals of 300 cells per microliter and above is quite sizable. So it's not a rare event. So I think it is the first sort of way for the COPD field to have the individualized, personalized medicine approach, a bit based on inflammation. We're getting there. We're not there where the asthmatics are, but we're getting there, and we're working hard on it.